where we discussed mainly AMP. So I want to go ahead and start off with the disorders of the pituitary gland. Let's talk about growth hormone. And growth hormone helps us grow. So we right now we're going to be discussing the excessive growth hormone production. So there's two primary conditions that we'll be discussing, and it's going to be your gigantism, and then we have your acromegaly. So keep in mind that in gigantism we have an abundance of growth hormone, and that's secreted early in life. Generally speaking, before puberty is over, before the growing has concluded. That's because the epiphyseal plates, remember the epiphyseal plates are the ones that are found on the epiphysis of the bones. So that location right there is what allows the patient to grow vertically. And so when you have an excessive amount of growth hormone that's secreted while you're still early in life, while your body is still developing and the epiphyseal plates are still receiving, or they're still open to receiving the growth hormone, that's when they get super tall, and that's your gigantism, okay? You have acromegaly, and acromegaly is a little bit different because it's also an increase of growth hormone. However, it happens after puberty is over. So it happens essentially in adulthood. And this is why your patients that develop acromegaly, it's more about their hands and feet that really show the difference in size, their skull formation, their tissues, their nose becomes more bulbous. Remember, the jawline, the mandible gets bigger, and so the teeth separate. And that's going to be important because us as nurses, what's our role? What's our role in this type of situation? Well, you have to understand the basic elements that this is usually caused by hypertrophy or a tumor that's found in the anterior pituitary gland, the adenohypophysis, right? That causes the excessive amount of growth hormone. And depending on when in life it occurs, it's either called gigantism when they get vertically tall, or acromegaly when their peripheries, their hands, feet, and other tissues, including their organs, get a lot bigger. Okay, so our role is to keep the patient safe. Both of these patients are growing really fast, and the muscles and ligaments and tendons aren't able to maintain stability fast enough to maintain safety, to allow the patient to ambulate without any type of unstable gait. So these patients have an unstable gait, and because of that, safety is very important for us to maintain with these patients while providing gait enhancers like a walker, or while providing maybe a cane, or anything that allows the patient to maintain safety, okay? Keep in mind, in gigantism, the body proportions are normal, okay? They're just really, really tall. And in acromegaly, it happens again in adulthood, and their hands and feet start getting bigger. Females develop more masculine features. They develop a little bit of hair, facial hair, a very more rugged look, more prominent eyebrow ridge. And that's what's essentially happening to these patients. So you must maintain stability with these patients. Now, when you have an excessive amount of growth hormone, we can do surgery to remove it. But before we talk about that, we have to talk about medications. And they're called somatostatin analogs. Because of the negative feedback loop, your hypothalamus is essentially monitoring how much growth hormone you have, right? So if the issue can be fixed with medications, we usually give medications like lanreotide, and these medications, they mimic the growth hormone, so your body will stop producing it. At least that's the goal. So the medication name is, whoops, let me get a better marker. Okay, I'm sorry. Hi. And this is the medications, one of the most common medications that we give for patients that have either of these two conditions, more so with gigantism, of course. We give the medications by injection every few weeks. So just keep in mind that this medication is given through injections. This is to suppress growth hormone so the patient doesn't get too tall. Now, if that doesn't fix the issue, then we do a hypophysectomy. And the hypophysectomy is the removal of the pituitary gland. And keep in mind that we can go into the gum line or through the nose, and we go through the sphenoid bone. So this is considered a transsphenoidal hypophysectomy because we're going to either remove the pituitary gland or the tumor that's found on the surface of the pituitary gland. And so we'll discuss post-op teachings in a little bit when we discuss some other conditions. But this, in a nutshell, guys, is going to be for your excessive growth hormone production. But we also have a decrease in growth hormone production. That's what I'm going to talk about next. So when you have a lack of growth hormone, well, that's called dwarfism. Okay, and so dwarfism is when the patient is growing up and their pituitary gland, for one or another reason, is not producing enough growth hormone, and this causes the individual to remain relatively short. But on top of that, their body does not really metabolize well, because growth hormone is one hormone that allows a lot of other metabolic processes to occur, such as sexual maturation and things like that, right? When you have dwarfism, the patient's not going through that when they're supposed to be going through it. So you have to remember that in dwarfism, they're going to be really small. They're going to have very delicate features in the sense that they're not rugged, they're not so masculine. So boys, let's talk about boys real quick. If a boy has dwarfism, usually at around the age of 12 to 13, that's when we begin puberty. But these patients are remaining relatively small. So we're going to give them what they're lacking. If they're lacking growth hormone, well, we're going to give them growth hormone injections, right? And these patients, we're going to give them growth hormone, but in addition to that, we're going to give them thyroid hormone. We're going to give them thyroid hormones because we want the body to be able to utilize that growth hormone. They could put it to work. And on top of that, when the patient is going through puberty during this age, we're also going to be giving, if it's a boy, we're going to give testosterone. Because we want the male patient to mature and to develop those secondary sexual characteristics so they don't develop depression because they're not able to mature like all their other peers at that particular age group. So it's important that we just keep those things noted, folks, okay? For females, of course, it's going to be the very similar condition in the sense that they're also underdeveloped in the sense we're focusing a lot on the sexual maturity because that's when the issues become more of a problem because of the psychosocial issue, right? So with females, we're also going to give them growth hormone. We're also going to give them thyroid hormone, but we're going to give them the female hormones, okay? We're going to give them estrogens, okay? We're going to give them progesterone because we want to make sure that they develop those secondary sexual characteristics so they don't feel that they're being left behind from their peer group and when it comes to their growth and development, okay, folks? So just keep that in mind. The lack of growth hormone could also be caused by hyposecretion or by a tumor that's causing the reduction of growth hormone secretion. Okay. Now, let's talk about some thyroid issues. So when we talk about thyroid issues, which is right here, this is your anterior thyroid gland, it's going to be your tropic hormone known as TSH, thyroid stimulating hormone. This is the hormone that sends its little signal to the thyroid gland so the thyroid gland can then produce its T3 and T4. Keep in mind that even though the thyroid gland produces calcitonin, when we talk about thyroid issues, calcitonin is not affected by this condition. Okay, so when you have an abundance of T3 and T4, which directly influence metabolism, when you have an abundance of T3 and T4, it could be caused by either a thyroid issue or a pituitary gland issue, okay? So keep that in mind because that's going to be the difference between your lab values. Let me give you guys an example. If your condition of, let's say, hyperthyroidism, if your condition of hyperthyroidism is caused by an issue at the pituitary gland, well, then you understand that hyper means excessive. So you're going to have an abundance of TSH. And because you have an abundance of TSH, that's going to signal the thyroid gland to produce its metabolic hormones, which is T3 and T4. And so when you look at your diagnostics, When the tumor is at the pituitary gland, your TSH is going to be elevated, as is your T3 and T4. Okay, guys, so I want you guys to understand this. When we're looking at lab values, if both of these are elevated, well, you know that this elevation is causing this increase in T3 and T4. So when it's a pituitary gland issue, both of those are going to be elevated. However, when you have a mass or a tumor at the thyroid gland, again, T3 and T4, those are going to be elevated because those are the specific hormones that influence metabolism. However, because of the negative feedback loop, your TSH now is going to be lower. Okay, so let me kind of illustrate that a little bit better here. When your tumor is at the thyroid gland is causing the increase in T3 and T4. So when somebody has hyperthyroidism, we know that the increase is going to be in T3 and T4, regardless as to where the tumor is at. But when the tumor is at the thyroid gland, well, yes, T3 and T4 is going to be elevated, but TSH is going to be low because the body is trying to fix the issue. Remember, I discussed all clinical manifestations are based on the patient's ability, the body's attempt to fix the current issue. And in this case, the issue is hyperthyroidism. And that's why we have high T3 and T4. But the TSH goes down because it's trying to signal the thyroid gland to reduce its production of T3 and T4. But in this scenario, we have an abnormal condition and there's a tumor or something at the thyroid gland. Okay, guys? Now, let's discuss some clinical manifestations. When we talk about hyperthyroidism, all metabolic processes are going to be elevated, okay? And this includes your heart rate, this includes your blood pressure, this includes your temperature. All metabolic functions are going to be increased. Your intestinal motility is going to increase. So let's talk about your GI motility is going to be increased. So if your intestines are moving really fast and they're pulling water consistently, you're going to have diarrhea. Again, we mentioned vital signs. The body's temperature is going to be elevated. The glands all over your body are producing their sebum and their sweat excessively. The hair becomes thin and very oily. This is what's happened to your patient with hyperthyroidism. Also, they're going to have a lack of concentration because there's so many things going on in their body that they can't focus. It's like trying to run on a treadmill and reading a book. I know some of you guys can do that, but it's not recommended because most of us can't really focus on the actual content when our body's metabolism is so fast. At the same time, you're going to develop something called exophthalmos. And exophthalmos is the terminology that we use to describe how the bulging of the eyes occurs. Now, you have a lot of circulation behind the eyeballs, and because of the high metabolism, it starts pushing the eyeballs forward, and your eyeballs are protruding. Not popping out just yet, but they're protruding. And you see a lot of people do this. Before we had TikTok and Instagram and social media, you used to see it on the Maury show or different talk shows where people would come in and show their extravagant abilities. So that's what exophthalmos is. Keep in mind that you as a nurse, why do you have to know about exophthalmos? Well, the eyes may become dry, so you have to lubricate them. As the patient's laying in bed and they're sleeping, while we're rolling around in bed, the eyelids cannot fully cover the eyeballs because they're protruding forward so much. So you may develop corneal scratches. So you have to protect the eyes with tape or with a patch like a pirate while they're sleeping to protect the integrity of the cornea, because if you develop corneal scratches, now you're going to have an obstruction in your visual field, and that becomes a problem as well. Okay, so that's what's happening in hyperthyroidism. I need you guys to understand that the patient with hyperthyroidism could develop an emergency situation. An emergency situation. And this situation happens when the patient with hyperthyroidism develops an exacerbation, an even higher problem, and this is known as thyroid storm. Keep in mind that in thyroid storm, if we have a problem in hyperthyroidism with all of these elements that we just discussed being increased, a thyroid storm is going to potentially kill the patient. The body's temperature may elevate so high that you have cellular damage to the brain, or the patient's heart won't be able to keep up with the metabolic demand that the condition is placing on the heart, and the patient may develop heart failure. So keep in mind that thyroid storm, the patient usually dies from pyrexia or from heart failure. Or heart failure. And keep in mind that you're going to be having some scenarios given to you guys in your questions. Like the patient just came back from a thyroidectomy, which is one of the interventions for this condition, which we'll discuss more in just a bit. Which of the following symptoms would the patient, would the nurse report, right? Keep in mind that this is very obvious. Pyrexia, a temperature of, technically, any temperature of 100.4 or more is considered some type of fever or something that has to be reported, right? But your questions aren't going to be that obvious. It's not going to say the patient has a thyroid storm. Which of the following will the patient die from? Heart failure is one of them. It's not going to be like that. It's going to be more like the patient, the scenario alludes to thyroid storm, right? And then which of the following would you report? You have to understand the foundation of pyrexia. Your temperature is going to be elevated, right? So you want to note any drastic increase in temperature. Even if it's from like 97 to 99.6 within like 30 minutes or a short spectrum of time, that's a red flag. You have to report that because you understand that in certain scenarios, such as a thyroidectomy, which we'll discuss in more detail in just a bit, the patient could develop thyroid storm. And a jump in temperature from like, let's say 97 to let's say 99.8, it's not feverish yet, right? But that jump is significant. Same thing with your vital signs. Anything that shows a sudden increase, those are red flags. If you understand the patient may suffer from heart failure when they have thyroid storm, you could say the scenario could be like the patient is, whatever the scenario is, that the patient might develop thyroid storm, right? Which of the following would be contraindicated? Well, since you know that the patient may develop heart failure, you don't want to give the heart any more demands. So you're going to go easy when you give fluids. You're going to go easy when it comes to physical demands on the body. And those are elements that you have to keep in mind because this is your foundation. This is what the patient may develop. So keep in mind that when you have hyperthyroidism, you could develop this emergency situation that's known as thyroid storm, and these are the things that are eventually going to kill the patient, potentially. All right. Now let's talk about some interventions for hyperthyroidism. Oh, and we could still elaborate a little bit more on some other key elements of hyperthyroidism. If the body's metabolism is excessive, then they're burning a lot of calories. You want to increase the calories in the diet. The patient is going to be skinny. The patient is going to be hungry. All those elements are going to be part of the concept that I'm trying to emphasize for you guys, okay? So make sure you guys understand the concept, because if you try to memorize the individual clinical manifestations, they get a little bit trickier, a lot to memorize. But if you get the concept, it becomes a lot more palatable, okay? Easier for you guys to digest. Now, when it comes to interventions, okay, oops. When it comes to interventions, let's talk about some medical interventions, okay? Normally we give something called propylthiouracil. This is also known as PTU, okay? And keep in mind that propylthiouracil is a very common drug for hyperthyroidism, and it may cause a decrease in white blood cell counts. So you want to report any indications of infection. That's very important, okay? They could be vague in the way that they present them to you guys in your question scenarios, but you have to understand propylthiouracil decreases immunity. You may develop infection. So you want to either report any indications of infection, or you want to prevent, or you want to stop any particular activity that may place the patient at risk for developing infection, like being around public areas, or maybe not getting vaccinated during a particular flu season and things like that. You want to avoid those things. You want to get them vaccinated. You want to make sure that they maintain their possibility of developing infection at the lowest possible level. And then we have another one known as methimazole. Okay. And so these are the two most common drugs that we use when we talk about the interventions, the medical interventions for hyperthyroidism. Now, if the medications don't do their job, then we have to find other means of, more aggressive means of decreasing the thyroid, the T3 and T4 production. So we can give something called I-131. And this is essentially radioactive iodine. Whoops. It's essentially radioactive iodine, right? Now, what you guys need to remember is that the thyroid gland, it needs iodine from our diet so it can produce T3 and T4. So the thyroid gland will always absorb iodine. Now, we don't have a lot of issues here in the States with the deficiency in iodine because table salt is iodized salt. It contains iodine in it, but in some instances, we could develop a goiter, which is when the thyroid gland gets bigger because of a lack of iodine. That's another topic. Right now, I want to emphasize the fact that we can actually create radiation and hook it up to the iodine. That's essentially what the medication is. And we give it to the patient. And we get a little probe, and we can actually put it next to the neck, and we can find out how much activity is going on there, how much of that iodine it's absorbing. We can tell because of its attached to the radiation, because of its attachment to the radiation. And that lets us know if there's hyper or hypoactivity. And we can use this medication to irradiate the thyroid tissue so it stops producing the excess amount of T3 and T4. It can decrease hyperthyroidism. It can hopefully cure hyperthyroidism. So keep in mind that we use this both as a diagnostic tool and as a medical intervention for these particular patients. All right. Keep in mind that if the patient has diarrhea, you don't want to give them fiber because fiber pulls more water into the intestines, which will exacerbate the diarrhea. Now, let's talk about some surgical interventions for hyperthyroidism. Well, remember, the issue could be at the pituitary gland, right? If that's the case, then we will do something called a transphenoidal hypophysectomy. A transphenoidal hypophysectomy is, if you can imagine, this is the brain, okay? And we, of course, have the skull right here. Let's just pretend this is the skull, okay? Well, what we do is we go through the nose, and we have to bypass this other little bone. That's a sphenoid bone. Or we go through the, we go through the gum line. We create a slit, and we pass through, and we put in a scope that has a little device that bypasses that bone, and then we can actually get to the pituitary gland, and we can remove it. That's your transphenoidal hypophysectomy. What you guys need to remember is that within the cranium, you have your brain, and you have a lot of cerebrospinal fluid. Yeah, cerebrospinal fluid, CSF. Keep in mind that CSF glucose level is between 40 and 60. And if the patient has any leakage of clear fluid after this procedure, you have to confirm that it's CSF. How do we know it's CSF? If the glucose value is between 40 and 60, or if we have what we call halos. And halos is just when the fluid leaks from the body, when the CSF leaks from outside the cranium, as it saturates different cloth material, the plasma and the CSF and any blood that's there separates from itself, and it creates these little rings that you see usually on the sheets or on the bed sheets or on the saturated gauze pads. Just keep in mind, when you see these halos, these are both indications that the fluid that's leaking is cerebrospinal fluid, and you must report it, especially after this procedure, because you don't want there to be any of that leakage, because that means that the meningeal integrity has been compromised and we have a problem, okay? Another thing that we have to really focus on is that this is essentially brain surgery, and you understand that anytime we cut into tissue, there's going to be some type of swelling, and the brain is here. And the brain expands when it swells, and we want to decrease something called intracranial pressure. You want to make sure that it stays low, because a patient that's had this procedure, hypophysectomy, they could develop increased ICP, intracranial pressure, too much pressure in the brain. That's going to compress the brain stem. It's going to change vital signs. The patient can eventually die, right? So what you want to do is you want to keep the head of the bed relatively elevated, not flat. You have to keep it relatively elevated. So 30 degrees or more. Okay, you don't want to put it too flat because that increases the pressure in the head. So you want to keep it 30 degrees or more. You want to prevent the patient from coughing. You want to prevent the patient from straining. So you want to give them stool softeners. All of these elements are important because you want to prevent ICP. Okay? Keep in mind that the patient that's had this procedure, if they had it through the gum line, then the patient will not brush their teeth for 2 weeks. Doesn't mean they won't have any oral care. It's just no aggressive brushing because you may dehisce the suture, that you may damage the suture lines, and the suture line may dehisce, and now you have a problem. So just keep in mind, folks, those are the elements that we are concerned with after a transphenoidal hypophysectomy. All right. Now, continuing with T3 and T4, we just discussed hyperthyroidism. Oh, and by the way, I forgot to mention, hyperthyroidism is also known as Graves' disease. Forgot to mention that. Now, let's talk about the opposite. When you have a decrease in thyroid stimulating hormone, this may also cause a decrease in T3 and T4, right? But the concept is still the same. What gland is causing the hypothyroidism? Okay, right now we're talking about hypothyroidism. Hypothyroidism. Okay, good. And hypothyroidism is a slow metabolic function, right? But again, these are the hormones that we know for sure are going to be decreased. But what's causing the decrease? Is it an issue at the thyroid gland or at the pituitary gland? So if the issue is at the pituitary gland, the TSH will be low because that's what's causing the hypothyroidism, correct? But if the issue is at the thyroid gland, then same thing with the whole negative feedback loop thing happens. Your T3 and T4 is going to be decreased because that's what's causing your hypothyroidism. But your TSH is going to be elevated because it's going to attempt to fix the issue. However, in this case, it's not going to fix it because there's a tumor or something at the thyroid gland. This is all part of the negative feedback loop. It's what your body does to try to fix the issue. Now, keep in mind, folks, that's the difference between your lab diagnostics, okay? Whether the issue is here or here, there's going to be a different correlation with the TSH. All right. When you have hypothyroidism, folks, all metabolic processes are low. So everything is slow, okay? I like to focus on concepts. So your heart rate's low, your blood pressure is relatively low. But on top of that, the glands in your body, they're also low. They're not functioning too fast. So your body's not producing too many oils. Your body's not producing too much sweat. These patients have a hard time keeping their metabolism increased. It's always low. So they're cold all the time. They have what they call an intolerance to cold. Keep in mind that these patients will have a low heart rate. They will also have a hard time focusing because their metabolic processes that allow the brain to function well is also slowed down. And we have to accommodate these patients by speaking more, maybe repeating a few of the instructions when the patient is having some post-op teaching or something like that. Keep in mind that these patients are going to be at risk for constipation because metabolic processes are slow, gastric motility is slow, and the patient may develop constipation. So because of that, you have to increase fiber in the diet. You want to increase fluids in the diet, okay? All those elements, the concepts are still the same. Now, in hypothyroidism, the goal is to keep the metabolism elevated, because if not, the patient could develop something called a myxedema coma. Okay? And this happens when the metabolic processes slow down so significantly that the brain essentially shuts down while still maintaining vital function, heart rate, respirations, but the brain shuts down, the patient's no longer home, and you slip into a coma. This is what we want to prevent. This is what we want to avoid. Okay? The patient with myxedema coma is going to have a cold intolerance. So keep in mind that the room has to be in relatively warm temperature, like 75 degrees, okay? You have to, again, increase fluids, increase fiber in the diet, things like that. But once they slip into that coma, that's what we lost. This is the emergency that a patient with hypothyroidism could develop. Okay, in hyperthyroidism, we talked about thyroid storm. In this one, it's going to be hypothyroidism. It's going to be myxedema, the coma. That's the issue that may develop. Now, how do we fix this? Well, we keep the patient warm, right? But on top of that, we give medications, and primarily we give levothyroxine Synthroid, because that medication increases metabolic function. And keep in mind that whenever we're medicating these patients to fix whatever condition they have, a side effect of the medication may be that they develop the opposite of what they usually have. Let me use this as an example. If we have hypothyroidism and the metabolism is low, we give levothyroxine, which is supposed to increase metabolism. Well, we have to look out for signs and symptoms of hyperthyroidism, because we might be over-medicating the patient and the metabolic functions may decrease. And those are things that we have to look out for and report to the charge nurse or to the doctor, depending on what your position is at the hospital, right? And that pretty much sums up thyroid disorders. All right. Now let's talk about some parathyroid issues, okay? The parathyroid gland, remember that it releases parathyroid hormone. And so parathyroid gland releases parathormone. And remember, parathormone increases calcium levels. So you could have either an abundance or a deficiency. The abundance is called hyperparathyroidism. And the deficiency is known as hypoparathyroidism. Folks, please ensure that you read these questions thoroughly and slowly to make sure you guys can distinguish between hyperparathyroidism and hyperthyroidism, because they sound so similar. Same thing with hypoparathyroidism and hypothyroidism. Make sure you guys are reading this correctly, because a lot of the times us as students, we jump the gun and we see one thing, but our brain sees something else, and this causes us to mix up the parathyroid issues with the thyroid issues. So let's talk about hyperparathyroidism first. This is an abundance of parathyroid hormone, which increases calcium levels as it is, right? So you're gonna have an abundance of calcium in the bloodstream. This is a problem because we're pulling it from the bone. So hyperparathyroidism is gonna cause a decrease in bone mineralization. And that's going to potentially lead to fractures. We call them pathological fractures. And pathological fractures occur without trauma. Usually the patient moving around in bed, maybe ambulating like normally patients do sometimes, and they'll develop a fracture. So we have to be very careful with providing this patient with safety precautions or safety measures so they don't develop fractures. We also have to keep in mind that we have to look at the body and be able to identify any indications of fractures, like pelvic fractures, maybe lateral rotation of the foot, maybe a shortening of the extremity, things like that. Crepitus, stuff like that, right? People that develop hypercalcemia, keep in mind that they're going to also potentially develop urolithiasis, which is kidney stones, because now you have an elevated calcium level, and that elevated calcium level is accumulating throughout the organs, and our kidneys filter our blood system consistently throughout the day, right? So we can have a collection of stones inside the kidneys, and we could develop kidney stones, urolithiasis. Keep in mind that to prevent urolithiasis, we want to increase fluid intake, okay? Keep in mind, because the condition is of high calcium levels, we want to decrease the calcium in the diet. Now, we know dairy products contain calcium because that's what the TV says, right? But we also have to keep in mind that a lot of green leafy vegetables, including broccoli, which is not leafy, but you guys get the gist, they also contain calcium. Anything that's fortified also contains calcium. So you want to make sure that you decrease the calcium in the diet. Now, calcium has a relationship with phosphorus, which we discussed earlier in the previous video. So if phosphorus and calcium have an inverted relationship, and phosphorus is the one that dictates that relationship, that controls that relationship, well, we have to decrease the calcium in the diet, and we want to give a high phosphorus diet. because we want to make sure that we pull that calcium down in the bloodstream so we don't have these potential complications of urolithiasis and potential bone demineralization. So please keep in mind, folks, dietary elements decrease calcium, increase phosphorus for hyperparathyroidism, which is essentially hypercalcemia. The muscles tend to get weak. Weak muscles when people develop hyperparathyroidism, guys. So just keep that in mind as well. All right, let us move on now to hypoparathyroidism. And I'm going to draw this somewhere else. So in hypoparathyroidism, the patient has low calcium because they have low parathormone, okay, or low parathyroid hormone. And this is going to cause the calcium to be deposited where? You guys should have said inside the bone. So when you have hypoparathyroidism, you have hypocalcemia. The calcium is low in the blood, but it's high in the bone. So the bones in this particular scenario, they become very dense, okay? And you'll be able to notice that in your bone density scans and other diagnostic imaging, that the bones are highly compacted because of the lack of calcium in the blood, but it's going inside the bone, so the bones are very dense. And this can also cause bone pain and things like that. Not necessarily fractures, but it can cause some bone pain and bone discomfort, mobility issues. Now, when somebody has this issue, that's not the worst thing that could happen, okay? We have to keep in mind that hypocalcemia can lead to an actual life-threatening condition known as tetany. Okay? And tetany is muscular excitability, the opposite of hypercalcemia, right? So when we talk about tetany, we're talking about muscle that's not how you spell it. Excitability. And this means that the muscles become very, very excitable, right? They become, they contract. And we're not talking so much about, we're not worried about your biceps, triceps, so on and so forth. We're worried about your laryngeal muscles, okay? We're worried about the larynx. Because your larynx is the voice box, and you have muscles that are surrounding the larynx, which allow the vibration so you guys can hear what I'm saying right now, right? The vocal cords, the opening of the airway, of the trachea. Well, if you have tetany, you may develop laryngeal spasms. And this is a big problem because if the airway closes, the patient suffocates and they die, okay? I want you guys to be able to recognize stridor. Stridor is going to be the adventitious breath sound that sounds like it's an upper airway issue. It's closing down. Those are all red flags. You want to make sure that the patient does not develop tetany because of this condition, because it can lead to airway obstruction, which will ultimately lead to death. Okay. Now, those are the main issues with that we were discussing so far. Now, if we go back to dietary or interventions, well, if we talk about interventions, this hypoparathyroidism, low parathyroid hormone, low calcium, so you want to give a high calcium diet. Okay, we discussed what elements have calcium in it. We want to give a low phosphorus diet because we want to allow the calcium to go back up. And since phosphorus dictates this relationship, we decrease the calcium in the diet so it can allow the calcium to go up. And then we want to give more calcium. We give vitamin D, okay? Phosphorus, what type of food products do you find phosphorus in? Keep in mind, it's all animal products, whether it's dairy, whether it's chicken, whether it's beef, primarily beef though. That's where you find phosphorus. So now you guys know when we're talking about increasing or decreasing certain elements in the diet, whether it's phosphorus or calcium, you guys also have to be able to identify which food sources contain a significant amount of that mineral or electrolyte or whatever it is. Okay, in this case, it's phosphorus. So just keep in mind, folks, that that's what you want to do. Now, when somebody, again, to relieve tetany, to relieve the whole issue with spasms, you want to give calcium. You want to give calcium IV. So whether it's calcium gluconate, calcium chloride, we want to go ahead and give it IV, because that's going to increase the calcium, hopefully instantaneously, and we don't have to worry about the patient developing stridor, laryngeal spasms, and eventually dying, right? Okay. And this concludes the parathyroid issues. Oh, two more things I forgot to discuss with parathyroid issues. When somebody has hypoparathyroidism, okay, low calcium levels, their muscles become very excitable, right? Well, you have these basic tests to see if the patient is going to develop tetany, and it's called the Chavastex and the Trousseau sign. And the Chavastex with a CH, you tap on a cheek, and the cheek starts kind of twitching. That's an indication of hypocalcemic tetany. Red flag. You have to start getting ready to implement medications or maintaining the safety of the airway, because you understand that if the patient has a positive Chavastex sign, the muscles are becoming irritated, the calcium is dropping, and tetany may result after that. The other one is a Trousseau sign. When you put a blood pressure cuff on the arm, you pump it up, and if the patient has hypocalcemia, they're going to develop tetany, their arm or their wrist will spaz in this fashion, and that's a positive Trousseau sign, and that's an indication of hypocalcemia, potential tetany. Okay? All right. Let us now discuss some interventions for both of these conditions, because there are some surgical interventions that you can carry out for both of those conditions. Now, essentially, it's going to be thyroidectomy. Now, let's not muddy the waters here. A thyroidectomy is for somebody that has thyroid issues, right? We discussed hyper and hypothyroidism earlier. A thyroidectomy is what you do when you have to remove the tissue. Now, the reason why I'm talking about both of these is because they're related, and I'll explain in just a bit. If you have a thyroidectomy, the post-op considerations are really important, okay? Behind the thyroid gland, actually, before I get to that, just keep this in mind. The thyroid gland has a lot of vascularization, a lot of blood supplies, and it's close to the airway. So we always have to remember ABCs, and for the first 48 hours after surgical procedure, outside of ABCs, bleeding potential is high, so you have to monitor for elements that may indicate bleeding. These patients, after the thyroidectomy, you must hold the back of their neck, or they must hold the back of their head, while they're moving around in bed, because if they hyperextend, the suture line is gonna dehiss, and you're gonna bleed out. So you must find some way to support the head as the patient's moving around in bed, so they don't hyperextend, so they won't dehiss. That's the first thing I want you guys to know. When you're looking out for bleeding, the patient will sometimes have a dressing on the anterior surface of the neck. You want to assess behind the neck, maybe on the pillowcase, underneath the pillowcase, to see if there's blood that's been collecting down there. Those are all important indications of bleeding. On top of that, you want to ensure that the patient does not have any laryngeal nerve damage. Again, this is after a thyroidectomy. The patient's going to be on voice rest, meaning we're not going to have them talk too much, because there's a lot of swelling, a lot of edema going on, and we don't want to be utilizing those muscles and those nerves while there's so much swelling, because it may cause potential bleeding. So we do voice rests, okay? We do voice rests. We have the patient whisper. Okay, we don't have them talk too much. But at the same time, we want to assess for nerve damage. And how do we do that? We ask them to say, "Sir, ma'am, can you go ah?" That's it. Just, can you say ah? And they go ah. If they can generate that sound, then we know that the laryngeal nerve is intact. It's not damaged, okay? Because you understand that during surgery, we are human, and sometimes surgeons make mistakes, and they may nick a nerve or something like that. So those are the really important ones, okay? Now, talking about the parathyroid glands. This is really important, because when we remove the thyroid gland, whether it's a thyroidectomy or a parathyroidectomy, you understand that the calcium level may now drop, because you're either inadvertently removing the parathyroid gland from the thyroidectomy, or we remove too much of the parathyroid glands, or we're just removing one. Now the other ones may have a hard time maintaining calcium levels. So understand that, statistically speaking, we're focusing on these issues that may cause serious consequences to the patient. So after a thyroidectomy or a parathyroidectomy, the patient may develop low calcium levels, hypocalcemia, which will potentially obstruct the airway and cause the patient to asphyxiate and die. Because of that, your job as the nurse is to be prepared for that. You have to be ready. So what do you want to have at the bedside? At the bedside, you want to have a trach kit. Okay, you want to have a trach kit so you can intubate the patient, not us, but the therapist, the respiratory therapist, or the doctor, so they can intubate the patient to maintain the airway patency in case it collapses because of laryngeal spasms secondary to hypocalcemia, tetany. You want to ensure that you have medications, emergency meds, such as your calcium gluconate that we discussed earlier, calcium chloride. You want to have those medications at the bedside, on deck, prepared for emergency administration in case the patient develops a positive Chvostek sign or a positive Trousseau sign, which are indications of hypocalcemic tetany. Those are really important for you guys to understand, to have them at the bedside in preparation for any potential abnormalities or any potential emergency situations. Now, focusing on the thyroidectomy. If we remove the thyroid gland, sometimes we still leave a little piece back. And after a thyroidectomy, the patient will be at risk for developing thyroid storm. Now, you might be wondering, how does that happen if we just remove the thyroid gland? Well, remember, we remove it because of hyperthyroidism usually, when the problem is right here. So we remove the whole thing. Well, what's going to happen to our T3 and T4 now that this is removed? It drops. What do you think TSH is going to do in response to the fact that T3 and T4 is gone? Well, it's going to start increasing its production of T3 and of TSH, because your pituitary gland doesn't know that we had it removed because it was malfunctioning. All it knows is that, hey, we don't have any T3 and T4 anymore because the thyroid gland is gone. So the pituitary gland starts releasing an abundance of TSH. If there is some remaining tissue in here, it's going to produce a significant amount of T3 and T4 because of the abundance of TSH. And that, my friends, will eventually lead to a thyroid storm. And that's where you have to look out for the sudden increase in temperature, the sudden increase in vital sign activity, because those are all indications of thyroid storm. All right, folks. All right. Let's talk about the adrenal gland. Now, the adrenal gland, we discuss the cortex. It releases aldosterone and cortisol, right? All right. Well, we have two basic conditions. We have something called Cushing's Syndrome, and we have something called Addisons Disease, okay? Both of these are opposite from one another. Cushing's Syndrome is elevated aldosterone and cortisol, and Addison's is decreased. Now, to help you guys memorize this, have you guys ever been to Venice Beach, let's say? Venice Beach, you've been on the boardwalk, and the Rastafarian guys come up to you and they go, hey, you want some Kush? Okay? What's Kush? It's some ganja, right? Some weed. Well, I want you guys to remember that Kush is weed, right? Let's see if I can draw it real quick. Not bad, right? So Kush is weed. Kush, when you smoke weed, it gets you high. I want you guys to use word association. Kush gets you high. So Cushing's syndrome is hyperfunction of these hormones. Now, none of this is going to matter if you don't remember that the adrenal cortex releases aldosterone and cortisol. None of this is going to matter if you don't remember that Cushing's syndrome deals with the cortex. But once you have that down, now to make sure that you don't confuse Cushing's and Addison's of which one is high, which one is low, Cushing's is hyperfunction and Addison's disease is the opposite, because you have to add to it. That's another way of memorizing this one. And that means that it's low. Okay? Let's talk about these two conditions now. When a patient has Cushing's syndrome, patient will have more sodium. Keep in mind that whatever the salt is in these conditions of adrenal gland issues, the potassium will be the opposite. That's important for you guys to know. So we know sodium is elevated because we know Cushing is hyperfunction of the aldosterone and cortisol. Aldosterone is salt, cortisol is blood sugar. So these patients, this is our foundation. This is what you guys need to know first. Your sodium will be high, your potassium will be low, blood sugar will be high. If the sodium's high, the patient's developing fluid, some degree of fluid retention, correct? Now remember, these are stress hormones. Okay, we're supposed to have therapeutic amounts, not an abundance of that Cush, right? Of that stress hormone. So what happens to you guys when it's time for a test and you guys go to class? Don't you find out who has herpes and who does not? What I mean by that is, when you're very stressed out, it suppresses your immune system, and that's when people flare up with their little cold sores, right? I want you guys to remember that. Stress suppresses the immune system. So people that have Cushing's syndrome, hyperfunctioning of these stress hormones, well, high sodium, potassium's the opposite, high blood sugar, and the patient will also have a depressed immune system. They're going to be at risk for potential infections. Now, when we talk about the immunity, we talk about the skin. The skin becomes a bit weaker. The patient, when they have this condition, they will also develop truncal obesity. Their torso is going to be relatively fat, okay? They're going to have striated or the stretch marks. They're going to have a buffalo hump. They're going to have moon face. They're going to have these issues with them, okay? They're going to have demineralization of the bones because they excrete excessive calcium as well. Guess where I'm going with this? This is what's happened to your patients with Cushing's syndrome, okay? They talk about it as buffalo hump, as moon face, but keep in mind that that's what's causing all these things. That's Cushing's syndrome. Let's talk about some interventions. If the patient has Cushing's syndrome, they have high sodium, low potassium, then that means that the diet, we have to give them low sodium, high potassium, okay? We have to be careful with the blood sugar. They may need a sliding scale. And because the patient's immunosuppressed, we have to maintain interventions that prevent the likelihood of infection, or we have to look out for indications of infection so we could treat accordingly. And that, in a nutshell, guys, is Cushing's syndrome. Now, Cushing's syndrome, let me talk about Addison's first. And then we have Addisons disease. Okay. Now, Addison's is the complete opposite of Cushing. So if Cushing is high, Addison's is low. So low sodium, and we know that whatever the sodium is, the potassium will be the opposite. Okay? We know that they're going to have low blood sugar levels, right? Now, these patients with Addison's disease, they also develop the book talks about a bronze pigment of the skin. Okay? Now, this is what the book says, but let's focus on the important things that you guys have to understand. These patients in Addison's disease, they have low aldosterone, low cortisol, but remember, these are stress hormones. So they have a lack or an inability to deal with stress. So one of the biggest issues that these patients are going to be developing is going to be hypotension. Okay? They're going to have low blood pressure because they have low salt in the body. And if they have low salt in the body, then the patient won't be able to maintain blood pressure. And so this is the issue that we really want to focus on with our patients with Addison's disease. Because they have hypotension, because of the low sodium intake, we have to take special precautions when these patients are dealing with stressful situations, like the loss of a loved one, like they're post-op, like they're about to have surgery, like they got sick, they got the flu, they got the Rona, they got COVID. Whatever type of stressful element is placed on this patient's body, whether it's psychological, psychosocial, whether it's physiological, anatomical, whatever the case is, wound healing, all of that stuff is stress. These patients will not be able to deal with that. So you have to understand that we're going to have to give them an increase in sodium, in fluids, okay? But we also have to give them appropriate medications. Now, the stress hormones that we're discussing, aldosterone, cortisol, these are your prednisone. This is your Solu-Medrol. your Florinef. These are the medications that we're going to have to be giving these patients with Addison's disease to replace the hormones that they don't have. I hope that makes sense. That's your medical interventions. Now, for both Cushing's and Addison's disease, when somebody has either of those conditions, just like in thyroid issues, remember how we discussed that the lab values of TSH and T3 and T4, depending on where the tumor or the issue's at, that's going to dictate the increase and decrease of certain hormones? Well, let's apply that same concept to this. We understand that in Cushing's syndrome, okay, this is elevation, right? So we know that your aldosterone and your cortisol are elevated. We know that. But what's causing the elevation? If it's a tumor here at the cortex, well, aldosterone and cortisol are high. What about ACTH? Because that's a hormone that tells the cortex to produce aldosterone and cortisol, right? So again, if the tumor is at the adrenal cortex, that's what's causing Cushing's syndrome. Your ACTH will be low because it's trying to fix the issue. However, if the problem is at the pituitary gland and we have an abundance of ACTH, now that's what's causing the increase in aldosterone and cortisol. So for when the tumor is here, both ACTH and aldosterone and cortisol will be elevated. Make sure you guys understand that when it comes to diagnostics so we know how to find out where the issue is, okay? Because if the issue is here, we can do that transfonodal hypophysectomy that we talked about earlier, right? Where we go in through the nose, go through the gum line, and we remove the pituitary gland of the tumor, and we have to look out for potential CSF leakage, halos, glucose, all that stuff that we discussed, right? ICP, a lot of stuff, huh? So we could do that, but if the issue's right here, and we have a tumor here, well, that changes the whole game. Now we have to give medical interventions. When we talk about medical, I'm talking about surgery. We have to do an adrenalectomy. Now, the adrenalectomy is the removal of the adrenal gland. Now, keep in mind that we have surgery around here to remove the adrenal glands. This is going to cause some specific post-op considerations. First of all, when you remove the adrenal gland, you're not only removing, you're relieving both the cortex and sometimes the medulla, right? So the hormones that we just discussed, aldosterone, cortisol, they drop, they're gone. So what do we have to do? We have to medicate the patients. We have to give them medications. Sometimes we give medications before the actual surgical procedure to make sure that we have some circulating aldosterone and cortisol in the system to prevent something called Addisonian crisis. This might confuse you. Follow me real quick. If the issue is Cushing's syndrome, hyperfunction, and it's being caused by an adrenal cortex issue, we remove the adrenal cortex. Well, what happens to aldosterone and cortisol? They drop. So the dropping of aldosterone and cortisol, that's known as Addison's disease, right? Well, in this condition of post-op issues after an adrenalectomy, the patient may develop something called Addisonian crisis. And Addisonian crisis may lead to hypovolemic shock. It may lead to hypovolemic shock. The patient has a certain marked decrease in sodium, and the patient won't be able to maintain blood pressure, and that can cause hypovolemic shock. So because of that, we want to replace the hormones. We want to give the medications after, even before the surgical procedure. But just keep in mind, that's we got to give them the medications so we can maintain those hormone levels and their therapeutic value so they can deal with the stress that this surgery is placing upon them. That's very important for you guys to know. Another thing you guys got to remember is that since the surgical procedure is here, what do we teach all post-op patients when we have invasive procedures somewhere in the thoracic area or anywhere for that matter, but when they've had general anesthesia, you have them cough and deep breathe every hour while they're awake. You have them use the incentive spirometer. But if this patient just had an incision right here, do they want to cough? No. So you have them splint the area to ensure that they can have maximum lung expansion by protecting the incision line so there won't be any dehiscence, so there won't be any evisceration. That's very important for you guys to understand. Okay, guys, after an adrenalectomy. Now, this whole Addisonian crisis can happen without this happening. Have you guys ever heard of if a patient is on, let's say, prednisone, and if they've been on it for a long time, what ends up happening is the prednisone, since it essentially mimics your stress hormones, for a person who doesn't have any of these conditions, right? A person who's just taking prednisone, let's say I have a Crohn's disease, which is an intestinal issue, right? And I take prednisone to decrease the inflammation. Well, I've been taking it for at least 6 months. Well, now I have these hormones in my bloodstream, and my ACTH stops producing what it normally produces because the hypothalamus is saying, hey, we already have a significant amount in our bloodstream. We don't have to worry about it. We don't have to produce all that ACTH. So if you're going to discontinue prednisone, you have to discontinue it little by little. Okay, you have to wean them off. You have to taper them off so the ACTH can start increasing its production as the aldosterone and cortisol start decreasing. Because of that, you should never discontinue prednisone abruptly, because if you do, you don't have enough ACTH to stimulate the adrenal gland to produce its hormones, and you'll develop Addisonian crisis. And again, the biggest issue is low blood pressure. But seriously though, hypovolemic shock. I wrote it twice now, so hopefully you guys understand that's the biggest issue that we're dealing with. Okay? I hope that makes sense, guys. I'm going to cover diabetes in another lecture. Thank you.